what I'm going to talk today, I've been studying connectomics for now 10 years. And you can ask, given that everyone else is on the agenda is talking about approaches or skull-based various things, where does this fit into it? And there's two things. Number one, there's an obvious thought of if we're trying to be minimally invasive, we should also be minimally invasive to the connectome. But more importantly, I think the keyhole surgery was the first thing that drove me into becoming interested in this topic. Because when you're making a really small craniotomy to do an interaxial supratentorial brain tumor, you really have to make sure you're in the right place. And what the last thing you want to do is open up and have your trajectory take you through a language area or some cognitive system that's really important. And so as I began giving this lecture, and I've probably given this close to 75 to 100 times now in some form, I've refined it to really what got me interested when I dove deeper into the field, of what I think this brings to neurosurgery. And so this is related to a company that I'm founder of, but we're not really specifically talking about the product. And what we're really talking about is this. So we want to get the patient on the left to look like the patient on the right as much as possible with as few complications and problems. Now, when it comes down to problems like motor or language or consciousness, we're pretty good at knowing that. We know where the brainstem is. We know the basic idea of how the language system works. And we have a pretty good idea on how to use various techniques, cortical mapping, DTI, whatever, to try to prevent those problems in general. But of course, there's a lot more to it. And if you talk to these patients afterwards, many of the particularly areas like the frontal lobe that we've really written off as being quote unquote non-eloquent, and thus we don't need to worry about it so much, often aren't doing as well as we think they are. And part of the reason is, particularly when we talk about gliomas, but really anything, is that there's a lot of other networks and complexity to the brain that we're not really paying a lot of attention to and haven't in the past. And not because we don't think those things are important, but because we don't understand it and we don't have a clear way to avoid cutting through these things. So when we start talking about this kind of issue, how do we minimize the cognitive morbidity of what we're doing? It's important to think about the fact that obviously you want to remove as much tumor as possible. These are bad tumors, and we want to try to get it out as much as possible. But in many cases, the more of the tumor you remove, the more likely you are to encounter problems. Because in many cases, there's functional tissue running through the middle of the tumor. And this observation was coined by Hugh Defoe to be as the oncofunctional balance. But in short, what it means is trying to make a good decision on how to define how far do you take this resection. And so if you look at the patient on the left, it's hard to say that taking a less aggressive approach, leaving tumor behind, is likely to save whatever you're worried about, given the aggressiveness and size of this tumor. But I think the flip side too is if you look at this patient on the right, this isn't a particularly large or complex tumor. It's just in a really bad location. And so it's hard to argue that increasing the extent of resection by 2 to 3 cc's is worth leaving this patient devastated, which is what you're likely to do going after all of this. And so as people try to talk about the concept of cognitive preservation, there's really not a lot of good advice that I found out there. Obviously, the traditional idea of stay out of eloquence areas is a good idea, but it really argues that the rest of the brain is, you can go hog wild there because it's just decorating the brain. We know that's not true. And we also know that when people say the opposite, which is everything is eloquent, well, that's not really true either, because we definitely can cut into the brain and get away with it. And so people have got into, well, can we use cortical mapping and things like this, awake surgery? And to be honest, I was very interested in this many years ago, but I'm disenchanted with it because I don't think that these kind of functions are in one place in the brain. I don't think that intraoperative tests give us clear answers, and so you're better off actually getting the tumor out if you can't really get a clear answer from a stimulator to say that you should stop. I don't think that we should do this on tests that don't have give up extended resection for tests that have unclear interpretations. And more importantly, how can we even save this stuff if we don't know the anatomy of what we're trying to preserve? I mean, the reason we've done okay with language is we basically kind of know where it's located. And so what I'm going to try to convince you is that we should use facts and data to reduce this uncertainty and gradually adjust our thinking. So over the last year or so, I've started to think about what is our path forward on this, and how do we reduce the cognitive footprint of what we're doing. And the first is that we should preserve the core of large-scale brain networks whenever we can. Okay, this is achievable now with existing technology and existing knowledge, and I'm going to talk a fair bit about this. The second is we should start thinking about the brain as a full network, and think about the idea of redundancy, parallel plasticity, but also that there may be limits to that. Eventually, we're working towards utilizing large, high-powered AI clusters to find parcellations or areas in individuals that may have more consequences than you think they do. And finally, we should think about the idea that we can actually change the connectome actively, and I'll talk about that at the end. So if you haven't heard of connectomics or the connectome, it's an omics, just like genomics. And that means it's big data, and it's big data for the brain connections. And so there are a lot of different ways to do connectomics, all the way down to electron microscopy. But if you're watching this talk, you're probably not doing that kind of stuff. And where the really most obvious clinical application is MRI-based technology, such as DTI and fMRI. And these are not new. So people have been doing this for over 30 years. There's 550,000 papers on this now. And so these are, there's not really a whole lot of debate about the basic validity. So you can argue this point or that point or accuracy or whatever. The bottom line is that we kind of know that these are telling us something about how the brain's wired up and how it works. And so the question is, why do we not have this on every single patient we see? And I'm not just talking about brain tumors or epilepsy, but pretty much everyone, because if it's giving us insight, then why do we just get regular T2s and nothing else? Seems kind of silly. Well, part of the reason is that it's really difficult to get this at most hospitals. And because we have to have a PhD, it's involved in this, and the software is not very useful. This really becomes the purview of a small number of centers, and it's very time consuming. And because we don't get it, we don't really know what to do with the information. But a really deeper issue is that even if you get an fMRI or DTI, the data is so complex and large and high dimensional that we can only glean a certain number of things to it. So we spend a lot of time, making beautiful maps of the corticospinal tract. That's really a small percentage of the connectome, and really only one thing. It's a very important thing, but there's a lot more in there. And to be truthful, when we look at an fMRI, this is what the scan looks like. It's not that useful by itself. But when we look at every pixel in here, what you're getting is a bold signal. You see that's that signal at the bottom. And that's telling you what's being activated at every time point. Now that's happening at every voxel in this scan at the same, at the same time point. And so these are the parts of the brain talking to each other. And so if you really do the whole math of this, the number of combinations needed to map all this is in the millions of all the possible variables in here. And this is something that humans really are just not cut out for. So one of the first steps in actually making this make sense, and really one of the best ones, is an old one. And so it's parcellation, which is when you divide the cortex into regions based on some kind of criteria. Now, everyone knows at least one scheme, and that's Brodmann's parcellation in 1908 that many of us had to memorize for our written boards. But if you look at it, the Brodmann, did a pretty good job for 1908. Many of his theories were pretty close to the truth, but he underestimated it for the obvious reason that he was working with far inferior tools to what we have today. And the Human Connectome Project published this parcellation scheme in 2016, estimating that the number is around 180 unique cortical areas instead of 47, which you can see here, this section on my brain. So as Charlie mentioned, when I first saw this, we started working on it as much as possible. And the reason for it is that there's some things that just struck me as soon as I looked at this diagram. So if you look at the clefts, for example, the opercular cortex, the outer surface is actually functionally different than the inner surface. And there are areas that sit inside sulci or cross gyruses. And so the bottom line is the brain really doesn't care what we call a gyrus or sulcus. And that's why the gyral sulcal patterns aren't very consistent, because it's irrelevant to the organization of the brain. Well, another thing that's really important about this is this gives us an alphabet to talk about areas. So if I talk about an area like area 8AV, we can all talk about the same thing. And that means we can actually make progress instead of just describing things in the vague way we've been doing for decades. So for example, the STG is a complicated area that sometimes has language on the left side, but sometimes it doesn't. And again, part of the reason is we haven't really been able to systematically improve on ourselves. So we basically studied this extensively, and we continue to work on this for the last couple of years now. I think we're up to about 5 years of work on this. And what we try to do is just map every area and then map them into large-scale brain networks. I'll talk about in a bit. But one of the things people said, and I thought it was really, good criticism, which was, well, this is really an impressive amount of work, Mike, but how do we actually use this in the real world? And so it's a good point. And what typically people do is they take an atlas of where these areas are and they warp it onto the brain they're operating on or start studying. But that doesn't really work for our kind of patients who, the bottom line is if you try to put this into most software, it'll just crash because it's, the shape of the brain is pretty abnormal. And so we spent the last couple of years creating a machine learning model that basically knows what those areas look like based on the DTI signature. So, for example, it looks at Broca's area and it learned how to assign parts of Broca's area based on the fact that it's connected to the things that Broca's area is connected to, like Wernicke's area. So this voxel would get assigned to Broca's area, this one wouldn't. And that it can address things like neuroplasticity or distortion by looking around the whole area and determining where the boundaries are. So this voxel would also get assigned to Broca's area and it moves the boundary. Now, this has a really nice property for things like brain tumors or people who have holes in the brain, because if it tries to assign Broca's area there's no connections. And so, it will have to find another answer to this. And this makes it very, very robust and lets us basically map anyone we want, and does this in a couple minutes. So this is the worst brain I could find to put in this model. And what you can see is that despite the fact that a frontal lobectomy has been performed, the brain is shifted forward into the cavity. There's a recurrent tumor. The machine learning knows where the basal ganglia is, even though the insula is shifted forward. It also knows what's missing. And given our really deep understanding of how this scheme maps onto large-scale brain networks, and given the fact that we can now map this on anybody, it lets us get to the idea of thinking about a really bad tumor like this. So we know it's bad, and we know that it's very easy to make this patient worse, and many of these patients have serious memory and cognitive issues. But it never really made a lot of sense to me when I was a resident why this is a memory issue, not a visual issue, given that what the splenium actually does, which is hook up the occipital lobes. And the reason is because this tumor is tucking into systems like the language, sensory motor, and most importantly, it's wrapped around the default mode network, which is one of the dominant cognitive systems of the brain. So now we know exactly why this is a cognitive issue, because that's what actually the tumor is pushing on and involving and invading. But more importantly, we can start actioning this, where we start to think about this in terms of a series of disconnections to get this out. And so at the minimum, we could at least remove a large portion of this with not putting the patient at substantial risk. And so when we talk about networks, it's important to talk about what are networks, because this is kind of a new concept. We've talked about tract preservation and eloquent area preservation, but this is really not how the brain works. No patient in the history of the world has ever come and said, hey, doctor, I really want you to save my tracts. They want you to save a safe function, and function is organized around brain networks. And so we should start actually talking about organization of the brain closer to the way the data actually lines up with how it really works. And so brain networks are areas that fire together, and they often serve a common task. Now, one of the things that when I first started doing this a couple years ago, I just wanted to know where was the list? How do I go memorize the list? And it turns out you can actually take networks and keep splitting them and splitting them, because they generally describe areas that fire together a lot of the time, but it doesn't mean they fire together all the time. And so the simplest way to explain this is that there are about 7 brain networks. These are the mega networks. And inside of networks like the default mode network, you can break off subnetworks like language. So language is closer to other language areas than it is to the rest of the DMN, but it's closer to the DMN than it is to the visual system. And so these are the main 7 networks: sensory motor, vision, limbic system. This is probably familiar to most people. Note that the orbital frontal cortex and temporal pole are part of the limbic system. The central executive network, the default mode network, the salience network, and the dorsal attention network. And so one of the things we started doing is trying to map these main networks into the HCP scheme by utilizing every single piece of the fMRI literature that had been performed that we could find, and then identifying who was activated in the same site, in this case language, and then making this into a map of networks. And we published a lot of these now. We're still working on this. So now once you understand who the components and the tracks that underlie a network, we have a pretty good idea where it is and how to minimize your chances of cutting it if that's possible. So I think there's 2 places that I usually try to talk about for neurosurgeons, which I think are in need of a major upgrade in our thinking. The first is that the concept of the control networks. Now, the control networks sit at the top of the hierarchy of networks, and they figure out how does energy and attention get allocated. And really, to be honest, there's 2 main modes. One is the default mode, which is what's happening when you're thinking to yourself, and then the central executive network is when you're thinking externally. With the Salience network, again, being discovered in 2008, it's a relatively new network, modulating the switch. So the default mode network is a big network, but the core part of it is this: posterior cingulate, anterior cingulate, and lateral parietal. The Salience network is a middle cingulate, anterior insula network, and the central executive network is frontal pole, the supramarginal gyrus, and area 8C. And so if you look at what's been mapped to this, the answer is a lot. Okay, so things like episodic memory, thinking to yourself, theory of mind, etc., are default mode network functions. Also, almost every mental illness has been shown to be a problem with one or more of these networks. Salience network has been mapped to things like pain. For example, anybody who has fibromyalgia, it's been shown a lot of these patients have problems with how the salience network works. As well, it's a fundamental network in things like depression. And the central executive network is really things like active memory. Now, where it becomes really interesting is when we start to use this stuff to explain things that we've known but not really understood. So we know that in messing around with the medial frontal lobe or injuring it, causing a stroke, is often causes some pretty serious problems. But what we haven't really ever known is what specifically does it mean to be, quote, bifrontal. And one of the things about it is it really, without having a sense of anatomy, you either just stumble into problems or you're just so afraid you don't go there. And what's more helpful is having an actual map of how the default mode network, the salience network, and the SMA interact to turn off the internal mental world and go into action. And so if you don't think that this is necessarily the cause of how you get akinetic mutism, note that this has been mapped in a PNAS paper by a group at Harvard that showed that akinetic mutism really only happens from this system being damaged and from injuring the brainstem. So this is pretty much a new eloquent part of the brain that we've torn the initiation axis. We've published a couple of papers on this now, most recently in Cancer. And the bottom line is we should probably try not to destroy this. Another thing that I think is worth an upgrade is we should really address the idea that Broca and Wernicke somehow in 1870 made a language system that was so brilliant that we can't improve on it, and this is all you need. Of course, that's ludicrous. These guys have been gone for a long time, and we know that if you actually start, paying attention to your patients, if you, especially in parts of the frontal lobe, but in general, sometimes this model really fails us. And this is actually one of the things that got me interested in this in the first place. And one of the biggest places is that if you mess around in the temporal pole, particularly for epilepsy, but also gliomas, and you start talking to the patients, they talk normally, they have normal fluency, but oftentimes they'll tell you that they have some kind of word finding problem, or to quote, the language is off in some way that the patient's family can't explain very well. And the reason is because there's a difference between speech and language. So answering questions and talking is a speech. Means the speech has been preserved, but that doesn't mean that people are actually making sense or really effectively using language. And so we really should recognize that there's a second system that's going through the temporal lobe. Now, even when we start talking about the speech system, what you look at here is there are numerous areas in the speech system, including areas that are not in Broca's area. So if you look at an arrow, that arrow 55B, that was discovered by the HCP and put in their scheme about 5 years ago. And there's been numerous work, including Eddie Chang writing a Cell paper. This is a case report he and I did together in neurosurgery, and then a group in Spain recently has published a larger series. And the bottom line is, this is probably the motor cortex for the larynx. And if you damage it, you get serious speech problems that have nothing to do with Broca's area or the SMA or anything like that. So the language system is a little bit more complicated. You can see in that upper left system, it really is centered around the temporal pole on the left side. And you can see those yellow areas show that the temporal pole is synchronized with Broca's area, but it's also synchronized with the rest of the DMN if you look at the anterior cingulate, posterior cingulate, and lateral parietal area. So if you look at all this, plus some other systems that I don't really have time to go into, this is probably a more accurate language system. This was a review paper that we published in JNS recently. Finally, I'll just briefly touch on this because in the interest of time, I'll go quickly. Again, if you look at these networks, they seem to be really complex. And remember that the default mode network you see here includes the language system, which is part of the default mode, but also the core language DMN that I talked about earlier. And so the question is, when you see this, it doesn't look like there's a lot of order to this. I mean, the motor system, the visual system, and limbic system are kind of in one place, but the other networks, the control networks, are all over the brain. And it turns out there's a real interesting order. So if you look at the interhemispheric portion, that's not really accidental. That is pretty much something that we see in embryology often as sort of like a segmental patterning scheme. And if you look at the DMN, posterior cingulate, anterior cingulate, onto the hemisphere, down to the inferior frontal gyrus, out to the parietal lobe, and down to the temporal lobe, in the sort of S. But the CEN does the same thing. The Salience network does something similar. And the dorsal attention network, which is a phylogenetically older network, does this too. And when we look at the cerebellum in this coronal section, you notice that the good portion of the cerebellum is not motor at all. In fact, it's actually the control networks being modulated. And if you see that red thing in the midline, that's the default mode network, which again, as I pointed out, is a language network, which should probably, given that that's the vermis, start to clear up the mystery of cerebellar mutism with Fermion splitting. But what's more interesting is when you look at this parasagittal section, you start at up at 1 o'clock on this diagram and go counterclockwise: motor, dorsal attention, salience, CEN, DMN, and then it does the reverse on the other side. And this is actually the organizational scheme of the basal ganglia as well. So the bottom line is the control networks are one of the dominant organizing principles of the cerebrum, cerebellum, and basal ganglia. So Now that we've taken that detour, how do we actually use this? So I wrote a book about this. And what we were trying to get across in the book is the fact that if you just use the traditional strategy of stay out of eloquent brain, don't cut the cortical spinal tract, and stay within the tumor, it's not bad advice. But the problem is that if you actually talk to the patients and pay attention, there's things that happen that aren't in the books. And even if you don't have deficits, like frank, obvious, in the hospital recognized deficits, the patients have cognitive morbidity that often prevents them from going back to completely normal. And part of the reason is that if you're not aware of networks and you cut through them, it causes problems. And the reason is because the brain didn't evolve to just to have CSF sponges. Everything is doing something. Whether or not we actually know about it, if we cut it, it still has the same consequence. And so what techniques like tractography and brain mapping, fMRI do for us is they take something like the Venetian Lagoon, which was this really treacherous area that protected the Venetians from invasion for centuries, and basically give it a framework, like the posts that you now see now that prevent the taxis from wrecking their boats. And so this is the white matter. It's treacherous, it's amorphous. And while tractography doesn't guarantee that you're not going to cut into this or wreck your boat, it gives you a framework to think about, what am I here to do? And so I think one of the things that really is worth pointing out is that skull-based surgery is difficult. I don't think anyone really will debate that, but there's one key advantage that skull-based surgery has that interaxial tumors do not. And it's that we can see the anatomy. We kind of know that the fifth nerve is there. And there's really nothing in the CSF space between that and the fourth nerve that is eloquent, that you would just accidentally, cause a problem that you don't understand. And so we do have a pretty good understanding of why we got the deficits that we got. Whereas the white matter, you don't. And you just step into things because the cerebrum is substantially more complicated than the trigeminal nerve. So in order to start to think about this as a set of anatomy, it's important to know that there are ways to start thinking about safe cuts and disconnections and trajectories. And while these may not be the perfect ones, this is based on the best available understanding of brain networks and the connectivity and tract anatomy that we came up with for the book. But again, this is something that we can continue to refine as we learn more about the brain. And so because we can make a model of a brain network, we are able to really automate this, where essentially we can say, okay, you're working in the medial frontal lobe. Here's the set of objects that are at risk in that procedure, and actually display it on image guidance. And so this was recently approved by the FDA, and it's available for sale in the United States and will be brought to Europe and other places later this year. But basically allows us to see brain networks and minimize our risk of cutting them. So when we start thinking about a disconnection, what do we mean? Now, if you look at this tumor, you could just start in the middle and take it one cell at a time, or you could go in here and work on the back and lateral portions and then take large pieces of it out. But however you do it, at some point, you're making a cut, which is the last cut between what goes and what stays. And so it's, what I would think about this is that instead of thinking about this as working in this orb and going until you hit the edges of that orb, like a meningioma, the reality is you're making these divisions. And so here you might not be able to preserve the default mode network, but at least you can see it. And this is something that we can start refining as we get more information over time. Now, another thing, and I'll run through these because they're interesting, but in the interest of time, when we start thinking about higher cognition, things like mathematics, it doesn't really map to a network very cleanly because it requires multiple networks. And so when we start looking at techniques that we can study the brain to minimize the challenges and to with thinking about the interaction of networks or how the brain works at a global level, we can take the brain, parcellate it, and then calculate how many fibers go between every region and every other region. And we can make the brain into a giant math equation. Now that seems interesting, but what do we do with it? And one thing you can do is really simple is to just say, who are the hubs of information flow in this brain? And so you can say, how many areas connect to you? And so that guy on the right there is the highest centrality on this diagram, because not only is he connected to 3 areas like the one on the left, he's connected to 2 really important areas. And so we looked at hubs, and we know that hubs express different genes, and they play a more important role. They're also more sensitive to Alzheimer's disease. But if you look at what hubs actually mean in a basic idea, these are the top 10 hubs of the brain across a number of individuals. And those guys there, if you were doing the Spetzler-Martin scale for an AVM, get you to the point. And those guys probably should get you to the point. And so the bottom line is eloquent areas are hubs. And so when you cut into them, you're cutting to hubs. And so then the question is, what if someone has a hub where nobody else has a hub? And so this paper was published in Journal of Neuro-Oncology this year. And what we basically just said was a simple question, which is, how often do people have hubs where no one else has a hub? And we looked at several hundred individuals, and the answer is about 7%. So about 7% of people have a hub in something like the frontal pole or the temporal lobe, or something that we don't think of as, quote, eloquent. But in that person, we may not be the place that you want to put your keyhole craniotomy. Now, again, another question is, are there hotspots in individuals that, for example, if you cut through this area, you can give a patient anxiety or depression, which is a pretty significant blow to their quality of life. And in order to understand this, you really need big data, because this is a very complicated data set. This is a pipeline that we've created. We can look at massive data scale and study about 5,000 patients an hour, running machine learning on them. What we're aiming at is to study connectivity. And so I'll cut through this really quick by saying that resting state fMRI is something that's much easier to get than a task-based fMRI, which is probably how most people think about it. The patient just lies there, but different areas activate or not activate all the time. And sometimes in certain disease states, things start firing together or not firing together in ways that are abnormal. And you can study that by saying that these areas are too correlated or they're not correlated enough. And you can do this for the whole brain. And so this is a term called functional connectivity. It creates massive data sets, but it does this on about an 8-minute scan that can be essentially, for the patient, is the equivalent of getting a flare. So this is something that can be done in a private hospital. This doesn't have to be done at Harvard. The key thing is that you just need the software to mine this kind of data. And beyond just being an academic exercise, this has clinical utility. So, for example, when we look at the disease depression, there's actually no such thing as that. There's about 4 different types of diseases that are very similar that we call depression. There probably are a lot more. And they have different connectivity patterns that actually lead to different symptoms, and they also lead to different responses to therapy. But these data sets are huge. So you can see this is about a 25 million dimensional data set of all the parts of every single part of the brain and how it talks to other parts of the brain. So we know that, for example, those red areas are firing together, the blue areas are anti-correlated, meaning they're firing opposite each other. And one of the things that we use to mine this is the fact that we've just done so much research on who these areas are that we get a pretty good idea of when somebody comes up the other side of what it's probably doing. And so this involves really large scale integration into hospitals to eventually really mine data at the kind of scale necessary to crack machine learning models. And we built tools for linking this to natural language processing, with the goal of basically essentially really trying to make machine learning models with the scale necessary to find individual regions that are important for specific functions. So I'll run through this real quick. This is just for interest. So when we look at things like mental illness, one of the reasons that these diseases have such mixed responses to therapies is that these patients have different diseases because different circuits map to different symptoms. So if a patient has 3 symptoms, they should have 3 circuits or 3 parcellations. And this is why these diseases have such tremendous overlap between different disease states. But if we can map it to areas, we can do something about it, or at the very least, we can not cut into it as a surgeon. So this is a big machine learning pipeline that we did to do that. And what it does is it gives us a list of individual regions that are responsible for symptoms. So in schizophrenics, for example, this is data from schizophrenia. And you can see that the machine learning knows that if you have problems in your auditory cortex or visual system, you might be hallucinating. But also, interestingly, the visual system is an epicenter of abstract thought, which is not something we would have thought of originally. So once we have this kind of granularity, can we do something to change the connectome? And this is something we've been doing for a while now to try to minimize neurological morbidity in patients. So this is where we basically use connectomics to understand the brain and to take an active role in driving rehab. And that means by brain stimulating patients. Now, this is approved treatment in most countries in the world, including the US. It's an FDA treatment for depression and OCD. We use it off label for neurosurgical patients. We've done many patients at this point. And while there's no randomized trial in this, there's some things in the world that don't need randomized trials, and this is probably one of them. In many cases, the responses are obvious and dramatically quick. And so how do you even figure out where to aim this thing? And this is where functional connectivity and structural connectivity come into this. So if you look on the left, all of those squares are red. And these are different squares comparing each square compares how two parts of the language system are communicating. So it's mostly red because language areas fire together. On the right, this is a patient with a GBM in the arcuate fasciculus. And so you can see it's blue because the language system isn't talking to itself anymore. But it's real, so it's kind of cool that we can actually look at aphasia. But here, that's a place in the brain. That's that one. And so we can basically pick squares off of matrix, turn them into targets, and then stimulate it. And that's what we do. So finally, just to show you that this is actually not a placebo, this is a patient with a pretty large MCA stroke. You can see on the left side, who was about 2 years out, came to our clinic for treatment. And what you can see is that the SMA basically doesn't communicate with the language system anymore. And this was probably the root cause of her language disturbance. We stimulated where that arrow is, and you can see on the right, that's pretty unmistakable that the tracks are substantially more dense. And this is known to be a neuroplastic therapy and can induce changes, in this case, which align with neurological improvement. And so, again, using machine learning, we can make this simple so that you basically, without having to have deep understanding of these, if you pick the comparison of two networks, the red and blue squares are trained on a machine learning model that tells increase or decrease connectivity compared to normal. And really, it's just as simple as picking columns and turning them into objects and stimulating them. So anyway, thanks, guys.